Hematology session. And for our first speaker in this session, we have Dr. Kathryn Gold, who is an associate professor in thoracic head and neck at the University of California. Dr. Gold completed her BS in chemistry at Duke University in 2001. She achieved her medical degree in 2005 from Washington University School of Medicine, and she did her postgraduate training at the University of Pennsylvania and in Texas at the MD Anderson Cancer Center. She has won numerous honors and awards, including the Young Investigator Award and the Merit Award through ASCO in 2011. She has multiple peer-reviewed publications, and today she's going to be speaking to us about the management of head and neck cancer. Dr. Gold.
Okay, thank you so much for the kind introduction, and thank you to the organizers for inviting me to speak today. I see head and neck and lung cancer in my clinic at University of California, San Diego, and I have to say for head and neck cancer, we haven't made as many strides as some other tumors have. The standard of care in a lot of ways is still the same as when I graduated fellowship now about 8 years ago. But I will highlight a few things that I think have changed dramatically. So my topics today will focus on 3 areas. I didn't want to do just an ASCO update, because to be honest, nothing that was presented at ASCO is really practice-changing in this field. But I do want to talk about therapy for locally advanced disease, focusing on therapy, as well as advances in the treatment of metastatic disease with new targeted therapies and open questions in immunotherapy. And then finally, I'll end up with kind of an orphan disease that had some new data presented recently, and that's cutaneous squamous cell carcinoma. So first, locally advanced head and neck cancer. As many of you know, most head and neck cancer presents locally advanced, over 50%, so it's very different from lung cancer, where the majority of patients are metastatic in diagnosis. I won't spend a whole lot of time talking about surgery, but just to say that surgery is still very much a part of the treatment for head and neck cancers, and I don't think we should forget that with all the advances in chemotherapy and radiation. But surgery is considered the treatment of choice for most oral cavity tumors and for T4A laryngeal cancers, and it's developing an increasing role in oropharyngeal cancers with TORS therapy, which is the robotic surgery. I took this picture here just because I think robotic therapy is pretty cool. I'm not a surgeon, I'm a medical oncologist. I knew early on that I was not meant to be a surgeon. But when you see, if you ever have the opportunity to see robotic surgery in action, it's kind of crazy. If you look at the picture, the surgeon is actually across the room, not even scrubbed, and is basically looking at a TV screen. It's almost like video game surgery, whereas there's a scrubbed assistant who's putting new attachments onto the robot, and then there's no one actually touching the patient. It's the robot that's doing it. So it's pretty cool. The main benefit of it is it allows surgery to be done in a smaller field than used to be done. So it used to be to take an oropharyngeal cancer out, you had to really do a big incision. It was a very cosmetically unpleasing outcome for most patients, but now these robot arms are a whole lot smaller than person fingers are, so they can get in there to places that surgeons couldn't do before. So now on, that's the last I'll say about surgery for today. Now on to our chemotherapy and radiation. So this is old data, but still important data. This is looking at a large meta-analysis of over 17,000 patients treated on different trials, combining chemotherapy and radiation in different ways, looking at either induction chemotherapy or concurrent chemotherapy or adjuvant chemotherapy. And the big winner in all of these trials was concurrent chemotherapy. So concurrent chemotherapy with radiation decreased the risk of death by about 6.5% in 5 years in a combination of trials. And most of that benefit, there were a lot of different chemotherapy arms used between the different trials, but the benefit was mainly seen in those containing platinum regimens, most frequently cisplatin at 100 milligrams per meter squared every 3 weeks. As you all know, anyone who's treated these cancers, this is toxic therapy, this is tough for our patients to take. And in this meta-analysis, no targeted therapy trials were included. But based on this meta-analysis and the trials included in it, our standard of care for most locally advanced head and neck cancers requiring radiation has been concurrent chemoradiation with high-dose cisplatin. Now, at the same time as many of those trials were being done, this trial was also being run, also known as the Bonner trial, which randomized patients with previously untreated head and neck cancer to radiation alone or radiation plus concurrent cetuximab with a loading dose of radiation is better than radiation alone. Cetuximab radiation is better than radiation alone. But what we don't know is what is the optimal cisplatin dose, and are cisplatin and cetuximab comparable? So right now in the NCCN guidelines, preferred regimen is listed as high-dose cisplatin, again, the 100 milligrams per meter squared Q3 weeks. And all these other regimens are listed as potential regimens, but not preferred. Now, how many people in the room have given high-dose cisplatin before concurrently with radiation? Okay, so a fair number of you. Radiation in the head and neck area is tough. I know we have a number of radiation oncologists in the audience, and what I tell my patients is side effects from radiation are all about location. It's the same thing as real estate. So breast radiation has a very different set of side effects than head and neck radiation does. The mucositis is pretty dramatic and really impacts quality of life during treatment and afterwards. And concurrent therapy makes that worse. There's no denying it. So to talk about cisplatin dosing, 100 milligrams per meter squared is the standard. We worry about a lot of things. There's ototoxicity and neurotoxicity, and those can be permanent, and also nephrotoxicity. I mean, we've all seen, I think, renal insufficiency that happens after using high-dose cisplatin. What we know, though, from retrospective analyses is that those patients that seem to get 200 milligrams per meter squared or higher seem to do better in the long term. So getting up to that 2 doses of concurrent cisplatin really is critical. Weekly cisplatin is thought to be better tolerated, and regimens of both 30 milligrams per meter squared weekly and 40 have been used. This is a large clinical trial that was recently reported that came out of India, Tata Memorial, where they see a ton of head and neck cancers. And it basically allowed any patient with locally advanced head and neck cancer either for adjuvant chemoradiation after surgery or for definitive, and randomized them to cisplatin at 100 milligrams per meter squared or weekly cisplatin at 30, so a lower dose weekly cisplatin, with the primary endpoint of local regional control. Now I want to bring your attention to the patient characteristics because this is different from what I see in my clinic. So almost all of the patients, over 90%, were either current or former smokers, with smokeless tobacco or chewing tobacco being the most common, or betel nut exposure. And 93% of these were adjuvant therapy, so oral cavity tumors that were resected that were getting post-operative treatment. So in my clinic, by far the most common thing I see is an HPV-related oropharyngeal cancer, so very different from what was addressed in this trial. But here are the results. Top is local regional control, and you can see that the once every 3-week arm had significantly better local regional control, although the overall survival on the bottom was different between the arms. But I think on the basis of this trial, we can safely say that weekly cisplatin for a post-operative smoking-related best of ASCO update, I did want to bring in some data from ASCO, and there was a SEER database analysis looking at this question presented at ASCO. So what they did was they took patients